Resource Center and the Agency for Healthcare Research and Quality, or AHRQ. I'd like to thank you for joining us for our fourth session of the Grand Round series of the Evidence-Based Practice Center, or EPC program. As always, this meeting will be recorded and shared with external audiences. So as you join, please drop your title or affiliation in the chat so we can get a sense of who's in the audience with us today. Next slide, please. So I'm Lucy Savitz. I'm a professor in the Department of Health Policy and Management at the University of Pittsburgh School of Public Health, and I'm also a senior innovation advisor for the UPMC Center for High Value Healthcare. And with me is my colleague and co-conspirator, Dr. Elizabeth Cope, who's Vice President in Health Systems Improvement at Academy Health. And we're here to facilitate the meeting with you today. So if we could have the next slide, please. So the meeting is going to be recorded again. And then, again, please use the chat during the meeting to add your questions and feedback as we go, and we'll be monitoring those and bring those up during the Q&A portion of the session. Next slide, please. This session has been approved for 2 continuing medical education credits. None of the speakers have any disclosures to report. And at the end of the session, there'll be a link in the chat that you can use to actually register and fill out the evaluation to receive those credits. Next slide, please. These are the learning objectives. So for those people who are attending the session today, we hope to identify key elements of effective opioid stewardship interventions that can improve patient safety in healthcare settings, describe the essential components of rapid response systems, and explain how it can help detect and respond to clinical deterioration, leading to improved patient outcomes. And then lastly, discuss strategies for engaging family caregivers through structured communications to enhance the safety of care transitions for patients. We have a great meeting planned for you. And so we have 3 report authors who are joining us today, and you can see them listed here on this slide. Julie Waldfogel, Bradford Winters, and Jesse Wagner. And you'll hear from them a little bit later in the session. On the next slide, please. And we have 3 discussants who've are guests of the SRC and Academy Health and have agreed to join us today and react to the report information that's being presented to you. So Dr. Tejal Gandhi is a Chief Safety and Transformation Officer at Press Ganey. Krista Hughes is a founder and CEO of Hughes Advocacy. And lastly, Sarah Scholle is a principal at Lovett Partners in Washington, D.C. So we're very happy to have them join us for this incredible discussion. I think you'll all be really happy that you joined today. Next slide, please. So first up, I want to introduce Dr. Farzana Samad, who's in the Center for Quality Improvement and Patient Safety at AHRQ, who will be joined by Eric Bass, who's at Johns Hopkins University Evidence-Based Practice Center. And they'll talk generally about the Making Healthcare Safer portfolio, and with a focus on the 4th edition of the Making Healthcare Safer report. So with that, Dr. Farzani.
Hi, everyone. Thanks so much for joining and engaging with us. This is just our standard disclosure that MHS was funded under a contract and that the discussion doesn't necessarily imply official views or endorsement by AHRQ. So we just wanted to provide some history on the Making Healthcare Safer report because it spans a few decades now. The first report was published in 2001 in response to IOM's To Err is Human, and it aimed to provide evidence on the effectiveness of interventions, or what we're calling patient safety practices, throughout the reports. And throughout the reports, it covers a wide range of series of various topics. These interventions are intended to prevent harm and reduce the risk for errors throughout the healthcare continuum. But because there's so many ideas out there and so many interventions and practices, MHS intends to help the field focus on implementing practices that are applicable to individual care settings, but also have an evidence of effectiveness. And overall, we also want to help researchers identify where there are gaps in the research and where they can focus on designing or studying interventions in the future. And if you notice, the first report was in 2001, the second was published in 2013, and the third in 2020. So they're quite far apart. And as you'll see on the next slide, starting with the fourth edition of MHS, we want to provide the field with the most current evidence, but have them available to you on a more timely rolling basis. So all of our reports are still posted on the AHRQ website, so you can still access them along your journey. And now I'll let Eric dive into the MHS4 initiatives and introduce the EPC teams who have really accomplished a lot in a really short time. So thanks so much.
Great. So first, I want to recognize and thank the entire team that's worked hard to support the work of the Making Healthcare Safer 4 initiative, including my colleagues here at Johns Hopkins, Dr. Treadwell's team at the ECRI Penn EPC, and Dr. Shakel's team at the RAND EPC. Next. In the first year of the MHS4 initiative, we recruited a distinguished panel of technical experts to help identify topics most important to examine. We considered 136 topics that were covered in past reports or that we identified in a systematic scan of emerging topics. We assessed each topic according to appropriateness for inclusion in the Making Healthcare Safer initiative, importance in terms of severity and extent of the problem, whether a report would be duplicative, whether it would be feasible, and whether it would have significant impact or value. The technical expert panel included representatives of many different stakeholders, and they used a modified Delphi technique to reach consensus on the highest priority topics for inclusion. Using the prioritized list, AHRQ assigned the first 13 topics for review. For each of these topics, we conducted a review to address 5 questions. Actually, let's go to the next slide. The main question was, how effective are the patient safety practices? What are their unintended effects? And what new evidence has been published since the last report? We also sought to address 4 contextual questions. How does the PSP prevent or mitigate harms? What are common barriers and facilitators to implementation? What resources are required? And what toolkits are available to support implementation? Next. For 7 of the topics, we performed a so-called rapid review using streamlined systematic review processes to complete the work under a compressed timeline. We tried to be very specific about the main question, limited the search to high-yield databases, and did sacrifice a little sensitivity to focus on the most valuable studies that were performed in the United States. For 6 of the topics that had more limited recent evidence, we followed the agency's protocol for rapid response reports, which were more narrative in nature. Next. In 2023, we then completed 7 rapid reviews and 6 rapid responses, covering the topics listed here. We'll focus on 3 of the rapid reviews in the discussion today. Next. After completing the reports, we convened the technical expert panel again to get their input about each PSP on whether hospitals and other facilities should adopt a given PSP, taking into consideration the importance of the problem, the rationale, evidence on whether it can improve outcomes, potential for unintended consequences, how hard it would be to implement, and each expert's experience that's relevant to the topic. We also asked about their priorities for addressing limitations in the evidence we found about the PSPs. Next, for each PSP, the technical experts had to choose one of 5 response options. Whether it should be strongly encouraged for improving patient safety, which we called for evidence to be strong enough to be certain that if we were choosing a hospital for care of loved ones, we'd choose a hospital implementing this PSB over one which was not. Second option was to be encouraged, which was based on whether there's enough evidence to determine that if we were choosing a hospital, we'd choose a hospital implementing this PSB over one which was not. But we have some uncertainty about the effectiveness or some concern about barriers or costs that kept us from putting it on the strongly encouraged list. The third option was to discourage it, which was if evidence does not justify concerns about potential harms, costs, or barriers. And then the fourth option was strongly discouraged, which usually was meant to apply if the evidence indicated that it's harmful or ineffective, in which case the costs could not be justified. We also did give them the option of not rating something if they felt they didn't have enough information to make a determination. So with that, I will turn it over to Dr. Waldvogel to talk about the opioid stewardship review.
Wonderful. Thanks so much, Dr. Bass, and thanks so much for having me here today. It's my pleasure to share our team's work on this rapid review of opioid stewardship. I'd like to start with a little bit of context about what we're talking about when we mention opioid stewardship, because there's no universally accepted definition for what that means. I like this definition here because I think it shares a little bit of the spectrum of what we're talking about. And so in this particular definition, opioid stewardship is the rational prescribing, but also the rational use and deprescribing of opioids. So that spectrum of care related to opioids. And it's notably also about maximizing clinical benefits for our patients while minimizing adverse consequences, again, both for patients and our community. So both matter, both sides of the spectrum are important. And so the purpose of this review was to determine that effectiveness based on those outcomes that we'll talk about in a second. As you can see here, as we talked about, some of these are reports that have been done before, and that was the case for opioid stewardship. So the opioid stewardship was included in Making Healthcare Safer 3. And in that particular report, they included a limited review that found moderate evidence that opioid stewardship interventions reduced opioid doses, but were not able to draw any conclusions about clinical outcomes or the impact of those interventions on things like pain. So just a quick little summary as we start going into some methods for our particular rapid review. For us, we searched PubMed and Cochrane for systematic reviews and primary literature, and you can see the date ranges there. Notably for us, the primary studies went back to 2016 as we were considering the release of the CDC guideline as kind of a notable moment in time that we wanted to track forward from. In our review, we decided to categorize the potential stewardship interventions into 6 main categories, as you can see here. So looking for interventions that related to organizational leadership, like stewardship committees, protocols, things of that nature, other policies. Clinical knowledge, expertise, and behavior. So how well did we train or include our knowledge base for our clinicians? Education and engagement for patients and families. Tracking, monitoring, and reporting performance data, which for us meant things like dashboards. Clinical accountability, which were things like prescriber feedback, peer comparison, and then certainly multi-component interventions, which could have included a number of those other buckets to be included in that particular intervention type. I just want to also notably point out what our particular rapid review did not include in terms of our kind of focusing. Our review does not include interventions that were focused specifically on the treatment of opioid use disorder. And we also did not focus on any interventions or policies that were established outside of a healthcare setting. So for example, interventions done by insurance companies, federal or state restrictions or regulations, things of that nature. For outcomes we were interested in looking at, you can see the different kind of bigger buckets for us for their outcomes. To be included in our rapid review, the studies had to include some measurement of a clinical outcome. If you remember what we talked about in the definitions, opioid stewardship is about maximizing clinical benefit, but also minimizing adverse consequences. And so any intervention we felt should also be measuring those things to see what the impact was on either clinical benefits or adverse consequences. And so they had to include a clinical outcome of some kind. You can see the kinds that we looked for here. They may also have included an opioid prescribing, so OMEs, total tablets, things like that as an outcome. process outcomes, so how much were we looking at your drug screening, treatment agreement use, et cetera. And then we were certainly also on the lookout for anything that would give us detail about how well these, and easy or not, these were to implement, so any barriers, cost issues, staffing issues, and things like that that the studies noted. So big bucket, big picture idea. Our review was able to include 14 systematic reviews, 13 randomized control trials, and 6 non-randomized studies. For the purpose of our conversation today, we are going to focus on that primary literature. And here's an overview of that. So our primary literature found studies for 5 of our 6 main categories for intervention, but truly most of our data was for 3 of those categories. So mainly our data is in clinical decision support, patient and family education, or multi-component interventions. And you can see the spread of number of studies here. We did have 1 study each for organizational guidelines and peer comparison. For the sake of what's coming in our next slides, we are going to focus on those first 3 just as the primary source of our information as we kind of summarize what that literature held. And so first up for us is going to be clinical decision support. So that category had 2 randomized trials and 1 non-randomized study. The RCTs were both about modifying opioid defaults in the EHR compared to no change. One study looked at changing all of the defaults to 10 tablets versus a control, and the other did 3 arms, a 10-tablet default, a 5-tablet default, and control. And the non-randomized study was implementing a headache treatment algorithm and following that over time. In summarizing kind of the study's results, for healthcare utilization, the randomized trials did not find any differences compared to control. So no changes in accessing the clinic, urgent care, ED visits, hospitalizations, things like that. The non-randomized trial did see at their second time period an increase in the number of admissions related to the headache treatment algorithm group compared to before. For opioid prescribing and ordering, a little bit mixed depending on the, for the RCTs, depending on which default we were referring to. So the 2 trials that looked at 10-tablet defaults did see consistent, similar reductions in total MMEs, less tablets prescribed and less tablets at 30 days following the initial prescription. The 5 tablets were not as consistent, so saw more no changes compared to control. The study argued that perhaps the study intervention group just felt like 5 tablets was too small and so had increased their tablets back up to 10 tablets compared to that. And the non-randomized study saw in general that after they implemented the algorithm, the headache group was less likely to be treated with opioids. In terms of clinical outcomes, no change in pain for the headache treatment group. The 1 RCT that looked at 10-tablet and 5-tablet defaults together found an increase in their reordering at 30 days. So they were more likely to have to reorder their opioid prescriptions at 30 days compared to the control group. But the 10-tablet group still total overall had less MMEs, less total tablets prescribed compared to control even at 30 days, even though the reordering rate was higher. For patient and family education, there were 6 trials, randomized control trials, all of which occurred in the ambulatory surgical setting and were basically about specific opioid education and pain education compared to standard of care perioperative education. I've tried to summarize a little bit the differences that were found in any of these trials here for you at the end, and pointing out the number of studies that looked at that particular outcome. So for pain, 5 of the 6 RCTs reported on pain as an outcome, only 1 of which saw any differences, and that was that lower pain scores were in the study group that got the opioid and pain education compared to the control group. 4 of 6 tried to look at opioid refills, and we only have 2 that saw differences, and they were kind of opposite of each other. So 1 saw higher refills in the group that got the pain education. The other saw higher refills in the group who got the control standard of care perioperative education. Everybody else saw no differences in refills of the 4 of the 6 that studied it. 3 of 6 looked at patient satisfaction. Only 1 saw a difference. And again, that was more likely to be satisfied if you got the pain and opioid education compared to standard of care. 5 of 6 looked at opioid prescribing or ordering outcomes. 2 saw reduced opioids filled or prescribed. And 2 of 6 looked at healthcare utilization and saw no differences between groups, again, and that's the category of ED, hospital admissions, things of that nature. For our multi-component interventions, this is our largest group. We have 8 studies here, 4 RCTs and 4 non-randomized studies. And in general, these are a combination of opioid education targeted specifically to the prescribers, so not to the patients themselves. Academic detailing, they had access to nurse care managers typically, and then also had facilitated access to specialists, meaning pain specialists, addiction specialists, psych specialists when needed. Just to start us off with things that were not different in any of the studies, just to get those out of the way before we look at things that might be a little bit more nuanced. For the studies that looked for these outcomes, there were no differences in pain between groups, early refill requests, or patient satisfaction between groups. And I've given you the N of the number of studies that looked at that particular outcome out of the 8 here for your reference. But here's the ones that maybe had a little bit of a mixed or different approaches depending on what was looked at. So for healthcare utilization, 4 studies looked into this as an outcome. One of the RCTs saw that the group who got the multi-component intervention had reduced ED visits. On the other hand, one non-randomized trial saw an increase in ED visits in the multi-component group. The others saw no difference in healthcare utilization. 6 studies looked at opioid prescribing or ordering. 3 of them saw reduced prescribing in the multi-component group. 2 saw no change in MMEs, which was the type of outcome they were looking at for this particular study, but did note that they had higher rates of opioid prescribing discontinuation. It just ultimately did not affect their total MME for the population. And then 1 non-randomized trial had no change in their prescribing over that period of time. And then 3 looked at general process outcomes. 2 of the RCTs did show an increase in their process outcomes, so more urine drug testing, higher percentage of opioid agreements signed, and a higher guideline concordant care, which basically means higher implementation of those process outcomes. And then 1 saw a mixed, depending on which of those process measures they were looking at, so increased urine drug testing, for example, but no change in the amount of PDMP use compared to their baseline in their control. And so here's maybe pulling that together again for us, a little bit of an overview of what we talked about. Remember, so we have 5 different buckets that had data for us in the primary literature, 3 of which had the more significant numbers of studies. We overall felt like the strength of evidence was low for each of those particular interventions. For our clinical decision support, we saw no change in healthcare utilization, but decreased opioid prescribing. Patient and family education saw no changes in pain, but some mixed results were on that prescribing. And multi-component interventions saw unchanged or improved pain, but also decreased opioid prescribing. And we felt like we had insufficient strength of evidence to speak to the 2 other categories that had 1 study each. Moving into a little bit of some practical things, or some things also to consider when talking about opioid stewardship interventions. We did look for data around barriers and facilitators, and perhaps none of this is going to be terribly surprising. But typical barriers that were noted in the literature had a lot to do with making sure that folks knew what to do. So lack of training, gaps in communication if we didn't know what to do or how to move forward with any monitoring. Making sure patients understood what was going on and were also buying into the process, making sure we had access to extra and additional treatments if we needed to, considering people's workload when implementing these kinds of things, and making sure everybody had a clear role. And perhaps understandably, the facilitators were mainly the opposite, right? So if we had a high engagement both from patients and clinicians and engaging in that intervention, it generally went better. If we made sure we had clear and frequent communication, good expectations, made sure everyone was clear with their roles and what policies they need to consider for the organization, and made sure we had some flexibility knowing any workload or workflow constraints that clinic or area might have. And we also wanted to look at what was out there for resources and toolkits around how to implement opioid stewardship interventions at hospitals. And the good news is there's quite a few out there. And so we've listed some of these as a resource in the report, and also here for you to see what might be out there. So certainly AHRQ has some resources, so does the AHA, the CDC, the Veterans Health Administration, and there's more on the next slide. So some more options for us from places like the Society of Hospital Medicine, the Institute for Healthcare Improvement, all of which have some relevant information that might help implement opioid stewardship and interventions at any given institution. So to summarize, we have 3 main categories that we were able to have primary literature for, all of which had low strength of evidence, in general for the decreased opioid prescribing and predominantly no changes in healthcare utilization. We have to be mindful of any barriers like lack of clinician training and workload, making sure we have good communication. And as long as we have clinician and patient acceptance, that's one of the key factors in making sure these are implemented well. And remember these publicly available toolkits and implementation guides to help when implementing these at your institutions. And so opioid stewardship, ultimately we felt like opioid stewardship interventions may reduce prescribing without harming clinical outcomes, but we should consider while reducing opioid use to monitor those unintended consequences, make sure we have access to non-pharmacologic pain management resources, make sure we do a good job with patient education and engagement. And here are, as Dr. Bass was mentioning, as it went back to the TEP for consideration, we brought them forward the three primary interventions, so clinical decision support, patient and family education, and multi-component interventions, all of which the TEP felt should be encouraged. And then they also considered any limitations in that evidence and felt like future research should really consider better outcome measures, assess further enhanced interventions, and think about stronger designs and methods of implementation to overcome barriers. But thank you so much for your time, and I appreciate and happy to take any questions.
Great. Thank you, Dr. Waldfogel. I'm going to ask the discussants to come on camera if you wouldn't mind. And if we could start with Dr. Gandhi. Dr. Gandhi, any thoughts or questions?
Well, I think I was hopeful that the strength of the evidence might have been stronger for this one, and it, it certainly feels like there's been so much activity in this area that I was disappointed in that aspect. But I think the technical expert panel's final conclusions make a ton of sense in terms of the need for more studies, and certainly the patient and family engagement component, as well as thinking about decision support and other things. So that was just my initial takeaway, is I actually was expecting that the findings might have been a bit stronger on this one.
Thank you. Ms. Hughes, speaking of patient and family engagement, I know that's near and dear to your heart. Any reactions or thoughts about what was presented?
Yes, I'm speaking through the patient lens as a patient advocate, and seeing these findings when it comes to this is communication is always, families are just not a part of the communication. There's not enough communication. You're left with, I don't know what to do with my meds. Should I stop it? It's a huge problem, and the communication has just got to be better in educating these patients.
Great, thank you. Dr. Sholey.
Thanks so much. So I had sort of three reactions to the findings. So one obviously is about how could you have an intervention that didn't have patient family engagement as its core, since this is really about a change that has such a huge impact on individuals and families. The second thing I wondered about is, what are the settings and how diverse are they in terms of the populations and the resources available? And so as we think about that communication, how does that communication address the needs of people that might have different cultural or language needs or communication needs, and how is that addressed? But also, what about the other services that are available? Because it's not just not prescribing the pain meds, but it's also understanding other factors that contribute to the pain, such as mental health or needs, and exposure to other kinds of adverse experiences. The second part is the availability of other services, non-pharmacological services, like anything ranging from physical therapy to meditation or other ways to manage when pain symptoms exist. And then the third thing is, as we think about outcomes, I'd love to see more attention to outcomes that get at how well people are able to function, not just their pain score, but how does pain interfere with their life, or how can they show that they're making progress in managing their pain.
Fantastic points, from all three of you. It sounds like we're laying out a research agenda. I want to note for folks that Taylor Dunlap on our team is posting the links to these reports, the rapid reviews, as they are discussed. So they are in the chat, and please chat in your questions at the conclusion of the 3 rapid reviews. We will have an open discussion, so we're looking forward to that. But right now, I'd like to again thank the discussants and turn to Dr. Bradford Winters, who's going to talk about rapid response systems. Dr. Winters.
Hello, can you hear me?
Yes.
Great. Well, thank you very much, everybody. I'm going to be presenting our work that we've done as a rapid review on rapid response systems, not to be confused with a rapid response presentation as part of the MHS 4 program. So for those who may not be familiar with them, rapid response systems are a patient safety intervention that was primarily developed to address the problem of unrecognized clinical deterioration on general hospital wards, and a problem that has come to be known as what's called failure to rescue. So for many years, it was recognized that patients on general hospital wards did not become suddenly critically ill. They were only suddenly recognized to have deteriorated to either a cardiorespiratory arrest or a near cardiorespiratory arrest. And starting in the late 1990s, primarily at University of Pittsburgh, as well as in Australia and New Zealand, they started implementing what they called MET teams, medical emergency teams, rapid response teams, what we now know as rapid response systems, to try to put into place a system whereby there would be better recognition that this was happening to a patient, and then put into place a response team primarily based on critical care intensivist providers who could be called to the bedside to evaluate a patient and hopefully stabilize the patient and prevent them from deteriorating worse to a worse condition, and especially to a cardiorespiratory arrest. So rapid response systems typically consist of four major components: the recognition and activation limb, also known as the afferent limb; a response team limb, also known as the efferent limb. That's where people think of the MET or the rapid response team. And good rapid response systems also include an administrative limb that oversees the system, as well as a QI limb that does constant evaluation of the local data and quality improvement. Common metrics that are used to evaluate the effectiveness of this particular patient safety intervention include the incidence of cardiorespiratory arrest, hospital mortality in a variety of forms. It can be total hospital mortality, unexpected mortality, and some other mortality measures may be used. Transfer to a higher level of care like an ICU, and ICU and hospital length of stay. Next slide, please. So the MHS3 report found that moderate evidence existed that rapid response systems are effective at reducing cardiorespiratory arrest. However, when looking at mortality, they found that the evidence was inconclusive as to how much and how rapid response systems actually reduced hospital mortality and impacted ICU transfers. So for this particular review in the MHS4 review, our methods included a focused search of PubMed and the Cochrane Library for systematic reviews and primary studies between the years of 2018 and 2022. And the articles that we were, and the manuscripts that we were able to glean from this search included 4 reviews and 19 primary studies looking at the relevant outcomes for rapid response systems. So let's first look at the data that we discovered looking at whether somebody has a rapid response system in place versus having no rapid response system in place. So just looking at it as an overall patient safety intervention. And I will tell you that the number of primary articles in this area, particularly in the United States and Canada, has really shrunk in the last few years, because ever since Patient Safety Goal 16 was promulgated by the Joint Commission back in 2009 to improve how hospitals address deteriorating patients in general hospital wards, most hospitals have already implemented rapid response systems. So hospitals that have yet to publish their data are becoming a much smaller group, but there are still a few. And if looking through the literature, we found 3 systematic reviews, one by Roca, Tumacusto, and Magahi, that all looked at the outcome of mortality with and without a rapid response system in place. And Roca deduced that there was a reduced mortality of about 15% with a confidence interval between 0.76 and 0.94 in adults. Tumacusto did not do a meta-analysis and provide statistical data, but reported that 7 of the 13 studies that they identified in their framework showed improvement in this particular outcome. Now, it's interesting that Magahi found absolutely no improvement in hospital mortality. Now, the Magahi report actually came out of the Cochrane database and was highly restrictive in who they included in terms of relevant studies. If we turn and we look at the primary studies, as we can see, there's several of them that look at hospital mortality. In particular, one by Young looked at unexpected mortality. And on average, we generally find that there are improvements. Giotra found no improvement in their particular study, but Winterbottom found a 27% reduction. Bactora looked at a series of epics over several years and found that there was an average of a 4% decrease per year over the several years of the study. Young et al. Found that there was a nearly 50% decrease, and that was reported as statistically significant. Makita looked in children post-cardiac surgery, finding that their death rate dropped from 4 down to 1. And Kavalos and Kuti, also in children, found significant reductions. Looking at cardiorespiratory arrest, Roca et al. Also looked at that outcome as a systematic review, also finding a statistically significant reduction with a relative risk of 0.65. And I will note that Roca's results back on mortality, as well as cardiorespiratory arrest, are actually very consistent with every other systematic review that has been published. Generally speaking, rapid response systems where meta-analyses are applied find about a 10 to 15% reduction in hospital mortality and about a 35% reduction in cardiorespiratory arrest. Now, Tumacusto did not do a meta-analysis again for this outcome, as they did not for mortality, but did report that 8 of the 13 studies that they included found statistically significant reductions in adults. And Magahi, again being a very restrictive study, systematic review, also reported no improvement in the incidence of cardiorespiratory arrest. Now, for primary studies, it was a little more of a limited data set. We found that Winterbottom reported a 65% reduction in cardiorespiratory arrest. Young did not find a reduction in incidence of cardiorespiratory arrest in adults post-cardiac surgery. And Kavalos, though, did find a significant decrease in the pediatric population. So a little bit of a mixed bag depending on which ones you look at. But again, we know that for all patient safety interventions, not everybody's going to realize the exact same outcome improvements or decrements. Next slide, please. So the other area that we looked at, actually 2 other areas, and I'll give you a little bit of idea of what we're going to be talking about over the next few minutes. We're going to talk a little bit about what's called afferent limb failure of the recognition and activation system. And then after that, we're going to talk about efferent limb structure. So rapid response systems, we have a large body of literature that sampling is laid out here on this slide that show that despite widespread rapid response implementation across the United States and Canada, this intervention frequently fails to activate in a timely manner or at all. And that failure to activate can range anywhere between 20% of the patients who meet criteria for an activation up to 50%. And of course, some patients, there's never an activation at all. And Boniati and Bucknell have linked this in their studies to increased morbidity and mortality compared to timely activation. And so we continue to struggle, even with rapid response systems in place, that despite having it in place, we still don't activate the team to come and see the patient. And while the number of studies with RRSs versus no RRSs has diminished, a large number of studies in the last 5 years have started to be published where people have taken existing rapid response systems and modified the afferent limb in order to try to improve their outcomes and address this resistant problem. Next slide, please. So let's look at some of these afferent limb modification studies and how they've affected hospital mortality. There are no systematic reviews that we found in our review, but there are a large number of primary studies, and they are outlined here. And as you can see, Vandergrift found a statistically significant reduction when they implemented certain modifications to their afferent limb, including an early warning score system. Weller found 40 and 30% reductions in an isolated population of neurosurgical and neurology patients when they applied wearable sensors to improve recognition. Interestingly, despite those large reductions, they actually didn't reach statistical significance, which kind of surprised us. Seabot et al. Found that a multi-pronged intervention to improve recognition and activation also significantly reduced this outcome. Escobar found the same using real-time deterioration score monitoring. Dean also did the same with EWSs. And interestingly, Bavare is a very interesting study. They looked primarily at children and compared family activation of the rapid response system versus having just clinicians activated the response system. So they instituted an opportunity for family members to actually call the rapid response system instead of just having clinicians do it. Now, interestingly, they found no mortality difference when they did this, but they did report that the underlying reasons why families would activate the rapid response system was drastically different than what was done by clinicians. Clinicians primarily activated the rapid response system for physiological deterioration, while families would activate for other problems, such as lack of a clear plan of care for the patient or lack of response by the primary service to their questions. So given that they have very different underlying reasons for activation, they felt that that explained why they really didn't see much of an improvement here. Next slide, please. When looking at cardiorespiratory arrest for afferent limb modification, again, it's a much more limited data set, but Dean et al. Looking in children, and again, Bavare found improvements, at least Dean did, a decrease of 0.31 per 1,000 patient days to 0.11 in the incidence of cardiorespiratory arrest. And again, Bavare found that cardiorespiratory arrest was less likely with family activation, but again, given that the underlying reasons for family activation were so drastically different from clinician initiated, they felt it was very hard to actually comment on them as a direct comparison. Next slide. Like afferent limb modifications, people have also looked at the efferent limb. While most people who work in this field believe that the afferent limb is where the low-hanging fruit is in terms of improving rapid response systems, there is some benefit to be had by addressing efferent limb improvements as well. And while the core problem of persistent failure to rescue likely resides with the afferent limb, several studies have tried to address some of the weaknesses that may exist in the efferent limb or the response team. And most of these weaknesses have been perceived to be things like lack of care protocols, lack of algorithms for care, perhaps less than optimal team membership and or skill sets, and inadequate hospital policies to help support the rapid response system. Next slide. So let's look at mortality. Several studies examined efferent limb modifications, some of which were also done in conjunction with afferent limb modifications. You'll see that some of these names also showed up on the afferent limb modification set of slides, but some also looked at it as a standalone intervention. And generally speaking, we find that efferent limb modifications, which can again include treatment protocols, enhanced data collection, changing the team membership structure, improving policies, etc., almost universally find significant improvements in the outcome of mortality. And now, unfortunately, all these studies were done in adults. We don't know much about children. Next slide. For cardiorespiratory arrest, 2 studies looking in adults, Sabat and Mankitty, also found for this particular outcome statistically significant improvements by doing these efferent limb modifications to improve the rapid response system. There was only one study that we found in children where they instituted care algorithms. That was a study by Sawicki, and unfortunately, they did not actually find any improvement in the pediatric population. Next slide. So evidence summary, but before I go into the evidence summary, you may notice that we found 4 systematic reviews, but we only showed data from 1. One of those systematic reviews was actually a study looking at the unintended consequences of rapid response systems. So how do they affect nurse staffing? How do they affect the care of patients back in the ICU when ICU staff have to leave the ICU to respond to rapid response activations on the general ward? And their conclusion in that systematic review, which we don't have a slide here for, was that they could not actually find any measurable decrement in care and unintended consequences, although theoretically you could have effects on nurse workflow and workload back in the ICU, but none were actually measurable. So the unintended consequences of rapid response systems don't seem to be at least a real problem that can be measured in studies. So to come back to our evidence summary, mortality may be significantly reduced. We may be able to significantly reduce in-hospital mortality in both adults and children. The strength of the evidence, however, is low. Cardiorespiratory arrest, we know that rapid response systems significantly reduce arrest in adults, but it's a little more unclear in children based on the evidence. ICU admissions, there's an unclear impact on unplanned ICU admissions, both in adults and in children, so there's insufficient strength of evidence. We did not find too many studies that clearly evaluated this in a systematic manner. But we do find that modifying rapid response systems, both the afferent limb structure and the efferent limb structure, can significantly reduce mortality and cardiorespiratory arrest in environments where there already is an existing rapid response system. This is especially true in adults where we find a low strength of evidence, but again, a little bit unclear in children, primarily because there are too few studies. Serious adverse events related to RRSs, at least based on that systematic review I just mentioned, in both adults and children appear to be very rare and uncommon, but again, there's insufficient strength of evidence. Barriers, facilitators, and resources implementing rapid response systems do face challenges like miscommunication, poor staff collaboration, and inadequate monitoring systems for general hospital ward patients. While resource requirements are unclear, a consensus is identified that key components for an effective system and basic toolkits do exist and are available out there, including AHRQ, IHI, and other organizations. In conclusion, overall, rapid response systems may have a large beneficial effect on outcomes of hospital mortality and the incidence of cardiorespiratory arrest. But again, the strength of the evidence is low due to methodological weaknesses of the studies and lack of studies in certain patient populations. Innovations in the afferent and efferent limb structures, however, do show tremendous promise for increased benefit in existing rapid response systems. So our panel, our TEP panel, after reviewing the evidence that we presented, found that 2 of the TEPs felt that it should still be strongly encouraged as a hospital patient safety intervention, and the other 12 found that it should also be encouraged, and 1 person was neutral on the subject, but nobody said it should be strongly discouraged or discouraged. And areas for future interest and research and focus to improve this area of literature and this intervention include studies to identify facilitators' barriers to implementation, and in particular focus methods on implementation to overcome the barriers. We need to have more studies with stronger designs. We need to expand the patient population, understand who benefits the most, study to assess further enhanced interventions, again, particularly modifications to the efferent and afferent limb. Longer follow-up studies are always needed. These tend to be the outcomes tend to only be hospital mortality, not long-term mortality. And we do need better outcome measures as well, more appropriate comparison groups.
Thank you very much, Dr. Winters.
No, you're welcome.
I'm going to ask the discussants to please turn on the cameras. And Ms. Hughes, let's start with you first. I was really intrigued to hear about the family engagement component of the rapid response systems. Any initial thoughts or observations from you?
I had just a few thoughts. As part of making healthcare safer and these patient safety practices, shouldn't patients be aware of these rapid response teams? As an advocate, I've never heard of them. I never knew they existed till I was asked to be part of this group. So how do we learn about these when your patient or loved one's in the hospital? And should we be educated on them to know more about them, or know if our patient's declining to improve patient safety? And would us being aware and helping, would that help with clinical outcomes?
I think absolutely. I think the education needs to be 2-pronged. Hospitals need to do a better job. They need to have signage up, saying, hey, we have a rapid response team. If you are worried about your loved one, depending on how they do the structure, some allow people to directly call the operator of the hospital to activate the team. Others will encourage the family to ask the nurse to activate the team. And if the nurse is asked to activate the team, they must do so. So we have to have better signage, announcements, some sort of education in the hospital. When you get all those brochures when you first get admitted to the hospital about all the issues that will be addressed, many hospitals don't hand out any brochure at all about this, which is why the public is probably not aware that this patient safety intervention exists. So hospitals have to do a much better job. But I would also argue organizations like AHRQ, IHI, all the other patient safety organizations across the country should get on the bandwagon and in some fashion make this a known fact. It has to happen on the hospital side too, but we also could do it on the national level. Saying to people, hey, you should ask about whether your hospital has a rapid response team. They probably do, but do they have family activation? Will you be empowered to get the help your loved one needs if you think they need it?
Great, thank you. Dr. Scholey, your reactions and thoughts.
So I went to that same place of
Mm.
thinking about families and caregivers as being, a tremendous resource because they know their family member and they can observe this. But I'm
Mhm.
also, as I looked through the studies, it seemed like there was a focus on sensors and scores, and so
Mhm.
I'm thinking about the future of kind of marrying these two pieces and building the communication around, well, how do you interpret this and why would it be important? And how can we work together? I'm also mindful, I realized that these studies did not address maternity care, but I am mindful of the work
Mhm.
that we know about the lack of trust and the lack of listening to people when they observe things and they're just ignored
Mhm.
in the hospital. And so I think just saying, here, we have this rapid response system, use it, is not enough. It really needs to be also an invitation and reception and trust and honoring when people say there's something wrong. And I think a lot of people might not either feel that they're being ignored. So it's communication for the staff as well. I'm also mindful that this is, we're looking at this in the backdrop where we have tremendous limitations on the workforce,
Mhm.
tremendous burnout. And
Mhm.
so trying to think about how to navigate from the place where we are to where we want to be in a way that we can um, help people that work in hospitals to feel more empowered and more supported, as well as to work more effectively with patients and their families.
Yeah, absolutely. You touched on a whole bunch of different things. Let me try to address as many as I can. Let me start backwards. The empowerment of staff is absolutely crucial. Like, for example, at my hospital, if there's any pushback from the physician services about a nurse activating the rapid response team, that gets escalated directly to me and the other co-director of the program and leads to a, shall we say, very terse email. That can't, that kind of bad culture can't be tolerated. And we take the attitude, if you see something, say something. So, for example, if you think you need the rapid response system, call the rapid response system. Our incidence of rapid response activations for what might be considered frivolous or a non-medical problem is near zero. Our system, and maybe we're underutilized. Maybe we do need to be utilized more. But I think you have to have a culture and that is going to support it. And rapid response systems alone can help drive culture, but they can't fix medical culture by themselves, so to speak.
Mhm.
That's a whole big area, but they can, and they definitely empower nurses. And you have to have administrators like myself who are going to back it up. Because if people like me don't back it up, then we're talking out both sides of our mouths, so to speak. Coming back to families, yeah, we need to make sure that people feel that they will be listened to. Obstetrics is a very important area. Now, there were a couple studies that didn't fall into this time frame of this particular review that are older, looking at the obstetrics population, finding rapid response systems for that particular subpopulation were beneficial. And there weren't any that landed in this particular time frame that we were looking at, but there are some older studies. But it's an area that still needs to be looked at more. The issue about workload is a huge issue. Alarm and alert fatigue is always the boogeyman in the background that you always have to worry about. You got to be sure that you're activating with a reasonable positive predictive value that something actually does need to be addressed. Because remember, in most hospital systems, because we are very strapped for people, we rob Peter to pay Paul. We're talking about teams that are primarily based on people who have another job. They're an ICU nurse, they're an ICU doctor, they're a respiratory therapist or pharmacist who's tending to other patients who then have to leave that patient to come to the patient's bedside. There's a lot of work looking at early warning scores, automated AI learning, et cetera, to activate these teams or to at least do a better job of recognizing that a patient might be deteriorating. They are tremendously promising, but they have to be able to do so without creating a lot of false alarms, or the point that you brought about stress workforce already is going to only be stressed even further.
Yeah, great responses. I'm going to also invite Dr. Gandhi, your reactions and observations.
Yeah, great discussion so far. I had one primary one, and then I want to actually quickly respond to some of the other themes that have been coming out. So,
Sure.
first of all, I do think this is a really good example of an intervention where the quality of implementation is key, right? And all those details about the afferent, the efferent, the monitoring, the quality improvement, et cetera. And I think that's probably why some of these studies, especially the reviews, were a little weaker, because how these are implemented is so important. And I think, having those toolkits and everything is out there is really helpful, but I think there really needs to be even more advocacy about, just because you check the box that you have it is not enough. And there's a whole bunch of details underneath that organizations need to implement to make sure they're really implementing at maximum effectiveness. And that gets at structure, process, and outcome measures, and cultural, and all of these other things. Quick comments. So I think the patient and family activation piece is absolutely critical. And, we have data that shows patient perceptions of safety are very connected to their overall, likelihood to recommend an organization, which is related to their trust in the organization, et cetera. So having these kinds of mechanisms where they feel like their safety is primary, that they can speak up, et cetera, is really critical. And I think, we'll probably talk more later about how do we effectively really engage patients, because I think there are a lot of challenges. On the workforce piece, I guess I have a little bit of a flip side, and I get the issues around burnout and workload. On the other hand, there's also, again, very good evidence that says if our workforce believes that safety is a priority and the organization's really committed to high quality, safe care, they actually are more engaged. And they're less likely to leave the organization. So I do think there's real positives to having this kind of safety net around them, so they know that help will come when they need it. So, and then one last point, sorry, I'm talking a lot about this one. On the AI front, I agree, there's a lot of opportunity. I was recently at a panel around unintended consequences of AI. And I think one of the challenges we'll have to think about as we go forward, because those systems are going to come, is making sure that we don't overly rely on the AI and we still value clinical judgment. So even if the AI isn't warning you, but you think something's wrong, that you will still be listened to. So anyway, lots of interesting details around all of the things that the other speakers have been talking about.
Yeah, actually, I gave a presentation at the 16th AHRQ PSO Summit 2 weeks ago now, and it was about AI. And actually, one of the things that I pointed out that I very strongly think the literature supports, but I also believe, is that you won't be able to take the human completely out of the element. We're going to probably never get to the point where a machine decides whether we're sick and sends a robot to the bedside. We can't allow that to happen. We need to let the machine and softwares, if you want to consider software a machine, we have to let them become our tool, but not our master.
Great comments, great discussion. Thank you very much. And again, we're going to move into Q&A after we hear the next rapid review summary in general across all these projects. So please chat your questions into the Q&A. And with that, I'm going to turn to Dr. Jesse Wagner. Jesse.
Hi, thank you. It's getting with this, so hopefully this works out, but I'm just going to move forward with assuming that it's going to bind. So I'll be providing an overview of our rapid review on engaging family caregivers with structured communication for safe care transitions, which is sort of a mouthful. But to provide a little bit of background, care transitions represent a critical point in patient care, which can lead to disruptions in continuity and coordination of care, can lead to adverse outcomes, including hospitalizations, readmission, ED visits, exacerbations of health conditions, and among other consequences. Clear communication between healthcare professionals and caregivers and patients is a key component of many frameworks that aim to improve patient safety during transitional care. As you can see, approximately 53 million adults reported being a caregiver in 2020, with almost 42 million of those being caregivers for individuals over the age of 49. Some organizations are exploring structured communication with family caregivers, which is unpaid informal caregivers, with the rationale being that it may improve clinical outcomes for patients, reduce preventable utilization and adverse events, reduce caregiver and patient stress and anxiety, and improve patient caregiver satisfaction. So next slide. So this topic was not covered in prior Making Care Safer reports. We did use the general methods outlined by Dr. Bassler here. We specifically searched PubMed, Embase, Cochrane Library for systematic reviews and primary studies published between 2010 and 2023. For primary studies, we included RCTs, non-randomized studies, single-arm studies that were all conducted in the United States. Ultimately, we included 2 RCTs, 6 pre-post studies, and 1 single-arm study, which focused on care transitions related to hospital discharge, ICU transitions, and residential facility transitions. Next slide. Just a couple of key concepts. So when we're talking about family caregivers, we're talking about, it doesn't have to be a family member. It can include non-familial, as I mentioned just a second ago, and it refers to informal or unpaid caregivers. Some examples might be a friend or a neighbor, or a family member or spouse who provide caregiving support to a patient. Structured communication. There wasn't a standardized definition in the literature, so we pulled this together from and use this definition to operationalize how we approach including these types of interventions. So structured communication is an approach to improve verbal interactions via use of standardized procedures, tools, or templates to facilitate sharing relevant information and better understanding by all parties. Next slide. So a couple examples of structured communication. So the teach back method, general checklists, bypass tool, computer assisted programs and modules embedded within electronic health records are all just for examples. Some of these were used in the included studies, and we'll talk about that in a second. Next slide. Next slide. So this is the summary of the overall evidence. We included 5 studies in the hospital, in hospital discharge. Of these 5, 4 pre-post studies and 1 with a single-arm study. And they looked at different outcomes. So 30-day hospital readmissions, 4 pre-post studies looked at that. 30-day ED visits, 2 pre-post studies looked at analyzed that. Caregiver stress, the single-arm study focused on that. And 1 pre-post study each looked at any post-discharge medical incident or adverse events related to the care transition. Unfortunately, all of these ended up with insufficient evidence to permit conclusions about interventions. For ICU care transitions, there were 3 studies, 1 RCT and 2 studies that looked at caregiver anxiety, caregiver depression, family satisfaction, patient satisfaction, and all of these also were insufficient to draw conclusions. Finally, residential treatment facility discharge.
Jesse,
Family caregivers who are
Jesse, you're
yes.
going in and out. If you can be sure you're close to your microphone, that would be great. Jesse, I think you're on mute. Celia, can we tell if he's still online?
I'm alive. Can you hear me?
Oh, okay, go ahead.
Oh,
Please continue.
Yeah, we can hear you now.
Okay, sorry, I don't know what was happening. So should I start over residential facility discharge?
No, just go ahead. Go ahead.
Okay. So this was in adolescents in a residential treatment facility for substance use, and the family caregivers were primarily parents. And it looked at a symptom exacerbation, which consisted of continuing to use different substances post-discharge, found insufficient evidence to make any recommendations or to draw conclusions about the intervention for that outcome. But then for caregiver satisfaction, we did find low strength of evidence that structured communication can improve the satisfaction of the family caregiver. So next slide. So that just to go over the implementation barriers, facilitators, and resources that are identified in studies for structured communication. For barriers, the studies identify high workload amongst teams being a challenge for implementation, and also competing organizational priorities at the hospital level was a challenge identified at least in one study. For facilitators, studies noted use of technology, so EHRs. One used subscription-based online program. Studies noted pre-implementation time to develop select tool processes and dedicated staff training prior to implementation. And then they also noted use of standardized tools and workflows as facilitators. Studies did not quantify the inclusion study, or that they did not quantify the resources required, but we tell from some of the descriptions that, so some resources might be the EHR, the subscription-based online programs, which likely incurred additional costs, needed staff expertise for implementation. And then two of the studies also used patient navigators and multi-component interventions, which required additional staff training and or expertise to deliver them. For our toolkits that are available, or four that we identified, in addition to one that was included in one of the studies, and these offer guidance and general resources on discharge conversations, medication lists, and patient engagement. So in conclusion, clear communication with patients and caregivers during care transitions is important, but there's limits on effectiveness of these safety practices. Structured communication, however, can improve caregiver satisfaction. Future research identifying items to focus on to assess potential harms of structured communication that was lacking from any of the studies we included. Specified resource requirements more explicitly, and include diverse populations and provide subgroup analyses based on different socioeconomic characteristics. So these are the top ratings. They were organized by settings, and so for the intensive care unit transitions, the TEP did not express a consistent viewpoint. 6 members encouraging or strongly encouraging adoption, 3 discouraging it or strongly discouraging adoption, and 6 identifying it as neutral or an area for further study. For care transitions, hospital discharge and other care transitions, the TEP primarily agreed that these are neutral or developmental areas. And yes, final slide. So these are the important priorities for future research identified by the TAP or ranked by the TAP. The primary recommendations were study designs and better outcome measures, studies targeting solutions, and studies focused on methods of implementation as the top ones.
Great, thank you. Thank you very much, Jesse. And if I could get the discussants to come on camera, please. And we'll start with you, Dr. Gandhi. Any observations or reactions?
Yes. I think probably my biggest observation is that, as we think about how to effectively do these kinds of structured communications, we really need to be co-designing with our patients and families, and make sure that's embedded into how we design these particular interventions, and actually our caregivers as well, of course, but really making sure we understand what the needs are of our patients and families, and doing this design together to make sure we're optimizing, to me, is going to be critical. And I know it was mentioned in the future research area, we do have to also really understand what the needs are for diverse subgroups, because those needs are going to vary quite a bit. So I think this is a very important area, clearly, and lots more research to be done. That co-design piece critical. And then the other thing I would just mention is sort of a new direction that I've been hearing a lot about as well, is around the tools that are available. I know there's a cost component mentioned, but there's a lot of opportunity to leverage tools like AI again to help with this communication, and not replace communication, but augment it. So for example, how do we turn a 5-page discharge summary that is maybe, or even a 10-page discharge summary, or 20-page, into this is at the 8th grade reading level summary for patients. And currently that's very labor intensive, but we have a future where that can be very relatively straightforward to do. So I think there will be a lot of interesting opportunities to study how those kinds of technologies can help us.
Great, thank you. Ms. Hughes, your reactions.
So this is a hot topic to me as a patient advocate. Patient and family engagement, care transitions, it's a tremendous issue. And it's where I see 100% of errors and harm are during these transitions. Families are being dismissed, not effectively communicated to. They're not part of the shared decision-making process. They're still being discharged too early when a patient doesn't feel ready, and then having to be readmitted. And there is a tremendous communication issue in care transitions to like a SNF, an IR, assisted livings. So this is just something that just lacks.
Great, thank you for that. Dr. Shuley.
As I was reading this, and of course, what we found across all three of these is limited evidence, right? There was, in the previous two, it was low quality of evidence, but more of a signal. And here it was just basically all but one area, insufficient evidence. And so that made me wonder, well, how intensive are these interventions? How much do they get? Just one kind of communication at one point in time may not be enough. And so in addition to thinking about sort of this co-design principle and understanding needs, and how understanding, what does it look like at that next setting that you're going to, I think really thinking about the intensity of the support that people need and how it might vary is important. I was thinking of a different way that digital technology could support people. Just thinking about how does, it's not just the transition from place A to place B. It's also, once you get to place B, what do you expect, right? And so it feels like it's not a one and done, but rather, developing a relationship that gives you support. And so I kind of go back to that. Where the rapid response system, how does this become not just education and a structured communication, but actually a structured protocol, so that if there's deterioration or if there's a question, right, it feels like that's where the gaps could be. as well. So and it feels like maybe, you know, the study designs or the interventions aren't strong enough yet.
Great. Well, I want to thank our discussants, Dr. Tejal Gandhi, Dr. Krista Hughes, and Dr. Sarah Sholey for this great, you know, reaction response portion of the meeting. And I'm sure you've, you know, sort of initiated some questions in other people's minds. I know we've gotten some good questions in the chat. I want to thank Eric Bass, Julie Welt-Fogel, Bradford Winners, and Jesse Wagner for their presentations. Now I'm going to turn it over to my colleague, Dr. Elizabeth Cope, who's going to lead the general Q&A of this moderated session. Elizabeth.
Thanks so much, Lucy. And I'll echo my thanks to all of the presenters and the panelists as well. This has been a fantastic discussion so far, and I'm pretty excited about the opportunity to have some broader discussion now and bring in the folks in the audience as well. And so we did have a question come through in the chat from Darla Stewart, a question that maybe I'll pose to Jesse, that is focused around what role did health literacy education play in the engagement strategies that you saw in the work coming through? So let me ask you that.
Right, so health literacy education then is structured communication interventions. In the studies that we included, there wasn't a ton of education. There was some of these were multi-component studies or multi-component interventions that include educational pieces. And then also some of them did start during admission and then carried over into the post-transition setting. So there were some pieces about education, but it wasn't super well described in the studies.
Great, thanks. Yeah, it sounds like there's been some limited discussion of it. Appreciate that. I think let me just, while we're giving, I think, the folks on the line a chance to get their questions together and start posting them in the chat. Maybe I will raise a question to Julie. So thinking about the barriers and facilitators identified in the research that you all looked at, what strategies can healthcare organizations implement to overcome challenges and promote the adoption of effective opioid stewardship practices? And here I'd really like you to think also in particular about how we think about this across different types of healthcare organizations. So I want to turn that over to you.
Sure, I think that's a very interesting question. I would say, so if we kind of reflect back on maybe the barriers to start us off, most of them had to do with like clear communication, clear roles, understanding the policies, making sure that any implementation accounted for workflow and workload already present in that particular community, and then making sure the clinicians and patients were on board with that intervention. And I guess what speaks to me out of that as a maybe overarching theme has to do with leadership, as maybe a way to start that would think about all of those as maybe a larger theme. So for me, and at least in my practice in considering opioid stewardship, I would say some of the best opportunities to work on those things have to do with making sure leadership is on board. And I mean that from the C-suite down in terms of the commitment to the idea of opioid stewardship and what those interventions mean. So that we can think about what it would take to implement something into a workflow. And the easiest and best way to do that also is going to be making sure that the clinic team and the managers of those teams and will make space for this. And we'll also consider what other roles that we need to consider to add it in and make sure that we kind of get that onboarding together would be part of that implementation process. So that speaks to me as maybe one of the key features that I think would support that work. But you make a good point also about, I think you were mentioning different healthcare settings. So I'm thinking a little bit about like primary clinics versus hospitals versus community-based places versus academic places. And I think I think that's still true, but I think also reasonably there's probably different resources at each of those sites that are going to impact that more than others. If we think about some of the multi-component interventions, some of those interventions included access to other specialists. And if you're in a rural clinic without attachment to other academic centers, that might be harder to implement as part of your plan if you don't have those access to those resources. And so I do think resource allocation is probably part of the answer to that question.
Great. Yeah, thank you. And I mean, yes, resource allocation, I think is it's always going to be one of those things, right? That comes to the front for all of us, I think, and across, frankly, all of the three topics that we're talking about today. But I'm just kind of curious because you raised this, and I mean, and it certainly came up in the barriers as well around healthcare workflows. And so, you know, what kind of strategies might there be for how you integrate these types of interventions into existing workflows as you think about ensuring sustainable improvements in opioid prescribing practices?
Yeah, it also depends on which intervention we're talking about, since the range can be pretty broad. So some of them hopefully integrate really well into workflows, especially if we're talking about integration into the electronic medical record. So if you think about the prescribing default intervention, there's not a lot of extra workload per se, because that's just something that's coming up default for those settings now, in hopes that that will be something that is easier for you to do rather than having to change it yourself. Although you could certainly in those interventions change it if you feel like that default doesn't fit this particular patient. I think some of the other ones, it depends on what we're talking about. The multi-component interventions to a certain extent were certainly more high touch, in that they involved clinical, like academic detailing. They involved a nurse manager that was basically the help to the workload for those particular interventions, to contact those patients, make sure that we were getting those like urine drug screens done, the opioid agreement signed, was following up on any extra refill requests and things like that. And so they took that workload and built it into their study, basically by giving it to this nurse care manager. So it depends on the intervention as to where that workflow adjustment would be. But and for example, the patient education interventions, everyone was already doing education ahead of time. We just, the intervention was just changing what type of education they got up front. So it really depends on what intervention people are going for, as to, I think, the answer to that question about how that would impact workflow.
Yeah, no, it's very true. Thank you very much. I think I will keep you in the hot seat for one more question that has come through the chat, and then I'll give you a break. But Lucy noted in the chat that dental procedures have been a place where opioid stewardship has been challenging, and just wondering if this came up in the studies that you all reviewed.
It did, and I should have said, so that was a miss on my part. One of the opioid default sites, so one of the RCTs that looked at reducing your total default setting to 10 tablets versus 5 tablets. One of those was in a dental practice at a academic medical system. So they had 2 or 3 different dental sites, and one of them had a 10 tablet default, one had a 5 tablet, and one had no change into their practice. So we do have one RCT included in this that's specific to dental practices. Memory serves, that's the only one, and that is the one that struggled with the 5 tablet. So 5 tablet really didn't see those reductions, and the argument in the paper was just that that practice probably just felt like that was too low of a default and kept backing up to 10 tablets. But the 10 tablet group did see consistent reductions in opioid prescribing over the course of that particular intervention.
Great, thank you. All right, let me move to Brad here. Let's give Julie a break. So we'll come to you. So there's a question in the chat around are there common metrics used to assess the quality of rapid response?
To count for immersion hours.
Don't listen to it.
Well, I mean,
Can we have
Yep.
folks please mute
I'm
themselves if
downloading
they're
it.
not
Just go to
speaking?
the synopsis and be like, oh, I learned this.
I don't know if it's
She doesn't even
possible,
ask
Taylor, for us
what we
to mute
learned, and I'm
other
like,
folks.
there's no proof of any
Oh, she doesn't, I thought.
way to attend.
Who is it then?
Let's see. There we go. All right, great. So there was a question in the chat. Are there common metrics used to assess the quality of rapid response systems response, and how is such data used in continuous quality improvement? Oh, you're on mute, Brad. think we've muted
Oh,
it.
I thought, so I think in the attempt to quelch
Yeah.
the other over, I got muted. Yeah, sorry. There are probably two major things that are used for rapid response quality that's reported, at least in the literature. One is how fast is the response time for the team? Because obviously we're talking about a patient who's potentially deteriorating towards cardiorespiratory arrest. That one's kind of a blunt tool, and I'm not sure personally how useful that is, because some of that's going to be dependent on the physical location. Like my hospital covers several city blocks. I know UPMC does as well. So response time, probably is going to vary a lot depending on the nature of your facility. But the other one I think that is important is triage. So let's say, I can tell you on average, if you look in the literature, it's reported that 50 to 70% of rapid response activations result in the patient staying on the general ward with a new care plan in place. So the rapid response team interfaces with the primary service, makes recommendations, probably does a few interventions themselves medically, maybe a few tests, etc. But the vast majority of those patients do wind up not escalating up to a higher level of care. And one of the most important metrics you can use there, and many hospitals do track this, including ourselves, is was there a second rapid response call on that patient, or did that patient transfer to a higher level of care or have another adverse event within 24 hours of the index rapid response call? That's probably one of the best ways you can look at, is your system addressing the needs of the patient and the staff? Because people have often argued that part of the purpose of rapid response systems are to rebalance an imbalance in patient needs to human resources that can be provided to that patient. And so one of the big questions comes up, was that effectively addressed during the rapid response activation? I would say that's probably one of the most important quality improvement metrics you can have, because if you have a high rate of reactivation of the team, or you still have a high rate of adverse events or escalation of care in that first 24 hours, clearly something's going wrong with the system. It's not doing what it's supposed to do. It's not rebalancing those resources to needs like it should be.
Great, thank you. And I just want to follow up a little bit on some of the findings from the work that you all did. And I think that this was a comment that was raised by our respondent panelists as well, but just thinking about sort of the overall quality of the evidence. But, what are some of the key considerations that healthcare organizations should be taking into account when implementing these kinds of systems, when you take into account the findings of your study? And how can providers really effectively navigate the uncertainties surrounding the effectiveness of these systems in doing so, particularly in pediatric populations, but also among adult populations as well?
Yeah, well, I'll address the issue with pediatrics right off the bat. If you look at like we have a pediatric hospital and we have the adult hospital, the incidence of cardiorespiratory arrest and mortality is much lower in pediatrics. So from a methodological point of view, you're already starting with a more rare outcome. Mm-hmm. And so obviously it's much harder to see statistically significant improvements with any kind of intervention. But obviously on the adult side, a hospital like mine may have hundreds of cardiorespiratory arrests a year without a rapid response system. So when you institute one, you may methodologically be able to measure a substantial improvement. In terms of addressing the lack of certainty that that these interventions have an effectiveness, is tough. When we first started our program, we got a lot of pushback about, well, what's the benefit of these? And the answer was, it was a lot of small, non-randomized trials. It's very hard to do a randomized trial because of the Hawthorne effect in an area like this. In fact, the Merit trial in Australia attempted to do that. They tried to do a pseudo-randomized study back in 2004. And it kind of failed on them. They found that they couldn't get a measurable improvement in the hospitals that got a rapid response team versus the hospitals that didn't. But they also found that was very interesting is they also did a before-after historical control
Mm.
assessment, and they found that all of their control hospitals dropped their cardiorespiratory arrest rate by the exact same amount that the intervention hospitals did. And then they went back and they looked, they found that their code teams were getting called all the time for non-coding patients. So basically, because of the Hawthorne effect, the hospitals that knew they were being watched because there was no way you could blind it, they started using their code teams as rapid response teams. And so there are some methodological problems and limitations that are going to inherently plague, this kind of intervention. I would argue that the evidence isn't perfect, but we don't have any evidence that anything else works any better at this point. And to let patients deteriorate on the general hospital ward without somebody coming and seeing them and trying to intervene, I just think is unacceptable.
Mhm.
So it's, it may not be perfect, but to be honest, it's the best we've got right now. And I'm very heartened that everybody's going back, including ourselves, back to their existing rapid response systems and working on how they can make them better and publishing that data. I wish they do a little bit better job on their statistics, I'll be honest. As you noticed in some of the slides I presented, not a lot of studies put a statistical, p-value in there. And I find that very, very frustrating. But I think that's partially the fault of the journals, letting those articles get through their review process without the reviewers saying, hey, where's your statistics, guys? You didn't put any in here. And I think that's a problem.
I think we're light on statistics, we're light on diverse populations, we're light on implementation details. I think we've got a fair
Actually, the
amount
one
of work
area
to
we
do.
didn't mention before that didn't come up, but I would like to throw out on the table. Right now, we don't know if rapid response systems, outcomes differ based on race, gender, LGBTQ status, etc. We look at the total patient population. Is there bias within rapid response systems? Is there a difference between how many people do get escalated? Is there a difference in mortality? Is there a difference in repeated rapid response calls? I haven't seen anybody publish that. I think that would be fascinating to know.
Mm-hmm. Yeah. Great. Thank you. Let me come to let me give Brad a break here. And I will come to Jesse. There was a question in the chat around how should communications, so this is for the structured communications with families. How should communications be adjusted for differing modes of delivery? So thinking about electronic and in-person, et cetera, and for different languages and literacy considerations.
Yeah, I think that's a good question. I'm not sure how I would recommend it be adjusted for different modes of delivery. Most of the studies, or all of the studies that we included, had essentially an in-person. It was an in-person, at least an in-person component, and then some of them had further follow-ups that was through electronic delivery or phone calls. So I think, at least based on what we've seen, all of it was delivered in person, at least at one point during the structured communication process. And some of these, as I mentioned earlier, started, some of them started the day of admission, sort of anticipating this transition period that's coming, and then extended it into the further, post-transition care. So I think it's, whether it's delivered electronically or in person, I think that in-person piece is pretty important. And then also, for if it were just electronic, I think it would need to be either, I'm thinking asynchronous might be difficult in order to assess patient understanding, caregiver understanding of follow-up care and next steps. So I think it'd be difficult, but it's something that could be studied for sure. In different languages and literacy considerations, that was a piece that I felt was fairly missing. And I sort of expected it to be a little bit more in the literature. We did have, 5 of the studies did report patient or caregiver language. and 3 of them included English-speaking and Spanish-speaking patients and caregivers, and then 1 of them included Spanish-speaking, English-speaking, and Somali-speaking patients and caregivers. But only that latter one provided any sort of subgroup analysis based on language. So, like I said, that's sort of, I mean, I think it's a big consideration when you're talking about communication, the literacy piece and language preferences.
Thank you. And let me kind of push a little bit more on that, because it was something that certainly has emerged across the different reports. And I think one that when we think about transitions in care and family communication is hugely important. But if you could speak a little bit to the gaps in the evidence base related to diverse patient populations here, and what the potential implications are there, and where you see the priorities for developing new evidence, that would be great if you could speak a little bit to that.
Right. So, I mean, sort of, as I stated, I think that health literacy piece and the language piece is really important and a big gap to address. There's also so in terms of other socioeconomic needs, there were some studies that looked at patient navigation programs that had a structured communication component. So we included those studies, and some of those did assess different needs that could be economic needs. It could be transportation. It could be access, like it could be education, and it could also be like sort of basic needs. So one of the studies, it was the same one that looked at the language subgroup analysis. They did, as part of their program, did an unmet social needs assessment. And then they helped follow up by connecting caregivers and patients to the appropriate resources. And they did that, I think, during the stay, but then also did some follow-up calls to see if there were any unmet needs. So I think that that's an important area for these, when implementing these interventions, but then also for assessment and evaluation.
Great, thank you. Yeah, and I really feel like things like cultural humility and other types of approaches to communication and considerations beyond just health literacy and language can be incredibly important. And this is a particular opportunity, I think, when you think about building trust between patients, providers, health systems at large. So this is an incredible topic area, I think, for additional research to be taking place. All right, well, thank you so much for this discussion. I really would like to invite those who are attending to please join me in thanking our 3 report authors yet again. And then I'd like to shift to a discussion with our invited discussants as we think about the implications of these findings and what those implications are when we think about policy, equity, and health systems. And so I'm gonna start us off thinking about the opioid stewardship intervention report and actually start us off thinking a bit more about equity, since this seems like an area that is ripe for additional evidence to be gathered. So let me just start with Dr. Gandhi, although I would invite all of our panelists here to respond here. But what consequences for equitable outcomes might there be with the growing uptake of clinical decision support and electronic medical record interventions for opioid stewardship? And here, I would invite you to consider both the algorithms and the underlying infrastructure for these systems, as well as the potential disparities between systems that are able to actually implement these interventions.
Thank you, Elizabeth. Thank you for the question. You know, we really do have to make sure we bring the equity lens as we're implementing these kinds of clinical decision support systems. And I think there's been a lot written lately about how decision support can potentially help with things like bias, but also can potentially perpetuate things like bias. And so I do think we have to think about both of those lenses. So for example, you know, if we are really uh, strong in how we design these tools, we might be able to narrow some of the gaps that currently exist because we are taking out some of the bias in the system. But also, depending on the data we use, we could perpetuate. And so I think understanding how these algorithms are built, understanding best practices of how to make sure that we aren't increasing bias, et cetera, is going to be really important. And we have to look at it over time and monitor as well to make sure that we're not widening gaps. So there has to be a measurement strategy as well with the segmentation that others have talked about to make sure that it's achieving the outcomes that we're anticipating. And I think the other component that you touched on in your question is also with any technology, there's a risk that the access is going to be differential, right? So we may end up in a situation of haves and have-nots, which, you know, honestly, that's where we are today in terms of some of these decision support tools that already are out there, and some organizations have the ability to develop complex decision support, AI, all that stuff, and other organizations don't have the internal resources to do that sort of thing. So I think that is always a concern we have. So how do we make it really easy to implement these tools, accessible, even for those organizations that may not have the resources to do it internally? And so I just want to call attention as well to the AHRQ recently released document, A Practical Guide for Implementing the Digital Healthcare Equity Framework, because I think that's actually a really great resource to help organizations really think about this equity question as they're thinking about digital tools that they have, et cetera. So I wanted to make a plug for that as we think about equity in these various components.
Yes, I'm glad that you made a plug for that. I was so delighted to see that report come out. So thanks for plugging that.
Rachel, you beat me to it. That was a report that I was lucky enough to be part of that team. And what I liked about that work is that it really does emphasize this idea of co-creation and you know, starting from the very, you know, conception of the work through implementation and evaluation, that it needs to be a you know, a team effort and involving the individuals who are the target. And as we think about equity here, you know, particularly in the case of the opioid stewardship, it's really understanding the needs of the patient population and the other kinds of resources they have available to them, and in under resource settings, how they manage with a patient population that may have fewer resources or different perspectives. So really interested in how that lens can be incorporated into these evidence evaluations, right? So how does that become one of the questions that you ask over time, and so that it's not sort of an afterthought, but it's actually part of the evaluation of the evidence or the creation of the evidence.
Great, thank you. And I see Celia has shared the framework and guide in the chat for those who are interested in perusing that in greater detail. Let me ask Ms. Hughes, I'll come to you first with this question. How can healthcare providers better support patients and families in navigating access to non-pharmacological pain management resources, as well as addressing encountered obstacles?
Well, in my opinion, most of my clients, when they go to their doctor in pain, that is what they're prescribing: medication, go get a massage, go get physical therapy. They're not just handing out opioids. the biggest complaint I hear from patient and families are, I can't afford a massage, or my insurance doesn't cover physical therapy. And sometimes they're in a lot of pain, and I wish that they would engage the families a little better on somehow to use a little pain medication with, meditation or whatever. But when patients are in pain, I feel like that's what we're hearing more of, is just do the non-pharmacological approach. And it's frustrating patients because they feel like their pain just doesn't mean anything. Or like I said, it's a money issue. I can't afford to go get a massage. So, and I work with clients all over the country. So I don't see a lot of opioid handing out medications.
Yeah, thanks for that. Because I do think there's we are navigating a pendulum swing, and trying to understand how we make sure that patients have access to all of the types of the full suite of resources, right, that they need, and the combination of those resources. And some of that access is awareness, and some of that access is the ability to actually pay for it, right?
Or it's take Advil, and then you're on a blood thinner, so you can't take Advil. So it's a problem because people don't want to do it, but then it's not helping the people that do need it. And I don't think we have found that balance yet. And it's back to communication and listening to your patient's needs.
Yep. Great. Thank you. Let's turn to thinking about rapid response systems. So, Dr. Schulle, I think I'm going to come to you first with this question, and ask you, what policy measures can be implemented to promote rigorous evaluation of rapid response systems, including measures to address heterogeneity, bias, and methodological weaknesses, to inform evidence-based decision-making and equitable access across healthcare settings.
Well, that was a mouthful.
I know. It's so
yeah.
take it away.
Yes. Solve the yeah. So this is interesting because as we were hearing about what potential quality metrics for these rapid response systems. So my mind, from my background in quality measurement, I was thinking, well, what are the existing quality or monitoring systems that we have? So I'm wondering, how could this be? Is there a way to implement this in the National Healthcare Safety Network that CDC runs, right? Is there a way to look at these, or in fact, is this already captured in the national, that's CDC, AHRQ has the National Patient Safety Database, is it in there? Are there ways to put, to make these rapid response systems and how they work, and maybe some of these metrics that we heard about the increased level of care or a second rapid response? Is there a way to put those in those systems? First, to kind of provide more transparency, to allow institutions to be able to compare themselves to other institutions, but also to kind of help us think through, well, is there a way for us to incentivize these better, or to use this? I also wondered about how to get feedback, and maybe Dr. Gandhi can help us with this, on whether there are ways to actually capture this information from individuals and or family caregivers about their own experiences. So some way for us to see this, because it's not going to be in claims data. It's hard to measure it, but we do have some ongoing systems for capturing safety issues. Could we move these cases into those settings?
Well, and I do think so. One area that I've been super interested in lately is this idea of how do we capture more patient voice around safety concerns and issues. And there's been some interesting studies recently about. There was one on a mobile app for reporting that it's always been a challenge of how do we make it easy for patients to report. And this group of researchers at UCSF actually made it really easy for patients to report. And it turned out they got a lot of reports, and it turned out they did a review, and many of those reports were validated as, yes, these are serious safety concerns, or safety concerns at least, and I think it was like one of them had shown up in the hospital safety event reporting system, and all the rest were not in that typical source. So I think we really do have to augment and make sure we're making it easy for patients to report these kinds of issues. And, you know, certainly patient experience surveys is another way, but I think there's going to be kind of a range of ways that we have to augment. And then we could be more targeted too and say, okay, it was about a concern related to your, you know, you or your family members' health deteriorating, or however you want to, you know, call it. Like, you could get more specific as well, but I think there needs to be, it's almost a cultural shift to say, you know, this is a huge gap that we're missing, this voice around safety, and we need to think of a very multifaceted approach to augment that.
And in that digital app, it seems like that would be more real time.
Exactly.
And could be tracked, right? So it's that piece that could actually allow people to say it in a way that doesn't require actually confronting staff person, which may be important if there's a lack of trust or a concern. So I'd be really interested in kind of thinking about, well, is that a mechanism that allows for to avoid issues around bias? I don't know whether, Krista, you have a comment on that.
I agree with that, because there is no trust, and everybody's worried if they do speak up, there's going to be additional harm to them. And my sister just had an emergency double bypass surgery, and she spoke up about a medication error. And just because I'm an advocate, I knew that her rights had been violated. And she was so scared because the nurse came in and actually bullied her without knowing what I did as a living. And my sister said, I no longer feel safe in this hospital, because she spoke up. She said, I shouldn't have said anything. And I said, no, you had harm happen. So I would like to hear more about that, because it needs to, no harm, you know, no bias. Because if it was happening to my sister, there was a, you know, Hispanic that spoke no English in the room behind us. And all I thought was, well, who's advocating for him when this just happened? So I'm very big on real-time data, it being almost anonymous, so there isn't further harm, because there is no trust anymore right now in healthcare from a patient perspective.
All right, thank you. This was an incredibly rich discussion. I think just in our last couple of minutes, I'm gonna switch gears to the since I'm actually gonna piggyback off of that, Krista, and come into questions around trust and relationship building as it relates to care transitions and communication there. So let me just pose to the group a question around, you know, what is the role of trust and relationship building in facilitating communication for safe care transitions, and how can providers incorporate trust building practices into their communication interventions? And I'm just going to pose that to all of you and see who jumps in first.
Well, you know, this is what makes me the most angry. And I mean, no disrespect, but I mean, I just literally had a client. Y'all have your data research. Mine's real time. Mental health issues. Can't make decisions on her own. We asked not to discharge yet, that it was too early. To please go over discharge planning with the family, especially the one that had guardianship, that he had run somewhere. And by the time he got to the hospital, they had dismissed her, and a van had come to get her, and she wasn't ready. We didn't know the discharge instructions. We didn't know, we weren't part of the plan. We didn't think she was ready. And 2 weeks later, she came back with sepsis. So families have got, it's the caregivers, the patient at that point, you know, if you've come out of surgery or something, I hate to say it, you're really not, should be getting informed about anything. You're not retaining anything. If they do not start including caregivers and the family members and engaging them with these communications, we're going to continue to have tremendous patient safety and harm issues.
Just to build on that, I mean, I know we're talking about this concept of trust, but I really think we need to flip it a bit and say we have to demonstrate that we are trustworthy. Because I think, you know, with the example just given and many others and all our safety concerns that we've had for the last 20 odd years, we have a lot of opportunities to make ourselves more trustworthy and really make sure that we are delivering care that is reliably safe, high quality, compassionate, and coordinated. And we have a long way to go on that. And so it doesn't surprise me that trust has been a problem. One thing I'll mention just as part of our high reliability, as high reliability frameworks that are out there, there certainly are kind of universal communication and relationship skills that are taught as a way of trying to build trust with our colleagues as well as with our patients, just ways of communicating. And those are things that many organizations around the country are trying to implement to really advance this communication in a more reliable way. But given the time, I won't go into all of that, but I just wanted to mention it. But I do think that, the onus is on us to make ourselves more trustworthy.
Or just empathy, apologizing. We had someone else did a medical error and she started off with I want to start by saying I'm sorry. Right then, everybody was like, okay, it doesn't matter what happened, we can work through it. It's just treat us like we're human. You make mistakes, we make mistakes. If you just apologize, that builds trust.
Yep. I think empathy and compassion can go quite a long way in terms of relationship building and sort of how do we work to make our systems safe, efficient, and effective, but also humanity affirming. I think those are things to try to center. Well, let's see, we are coming close on time, but I want, Dr. Scholle, is there anything you wanted to contribute to this part of the conversation?
I just want to double down on what the other discussants have said, and this idea of how we do it in a intentional way, in collaboration. I mean, it is building the trustworthiness of the healthcare organizations and institutions. But part of that is reaching out to understand what are the sources of lack of trust, and how do you build the relationship, because trust is built on a relationship, a shared understanding, a shared goals. And so I think actually really trying to create that relationship and make that part of what the incentives are for organizations, so that it's not as much on financial considerations or other things that are less tied to the individual's experience alone.
Thank you. I know I'm looking at the clock and it's like, whew, this time went by quickly, didn't it? So I want to say thank you to our discussants so much for sharing your expertise. I'm going to ask Taylor to share the CME survey link in the chat for those who need it. And if you are seeking continuing medical education credits, you do need to fill out this form. So please do that. And then I will just turn to all of you and say thank you so much, everyone, for joining us and participating in today's conversation. Again, I want to extend another thank you to the report presenters, Julie, Brad, and Jeffy, and to our discussants again, Tejal, Krita, and Sarah, and of course, our partners at AHRQ. We are going to share this meeting's recording as soon as possible, and then we will announce the next EPC Grand Rounds theme shortly thereafter. So thank you all for joining. This was a pleasure. It was a very rich discussion. And yes, a huge thank you to Taylor for all of her support and logistics coordination on this. And so thank you to everyone and have a great rest of your day.
Bye-bye.